Good evening, everybody. Delighted to welcome you all this evening to the Arthritis Ireland Women and Arthritis webinar series. And we have our first episode this evening. My name is Gráinne Murphy and I'm Chief Executive here in Arthritis Ireland. So before I introduce you to our speaker, Professor Gráinne Murphy, I'm just going to go through just a few pieces of information on Arthritis Ireland itself. But first of all, I'll just talk about our guest speaker this evening. And that's Professor Gráinne Murphy, who is a consultant rheumatologist in Cork University Hospital. She was also a founding member of the Rheumatology Specialist Interest Group for Women's Health. And her research interests include the immunological basis of SLE, women's health in the context of rheumatic disease, and vasculitis, in addition to MSK ultrasound. So very broad range of interests there. And we're very, very thankful for Gráinne for joining us this evening. So just a few things for those of you that are tuned in that, may be less aware of what we do as an organization. And we always use our webinar series as an opportunity to tell you a little bit more about the work that we do. So you might already know that we're a national charity and we are the patient organization for people living with arthritis in this country. And we are really all about delivering support, training, education and information for all of the almost 1 million people in this country that are living with some form of arthritis or a rheumatic disease. I always point people to, first of all, to our website, which is arthritisireland.ie, because there you will find a wealth of information on what we do, what's available, and how we can support you. So, for example, we have a range of information booklets and other information resources on our website. We also have information then on our various programs that we run. And I'll give a special plug to our self-management programs, which are 6-week interventions that we run in the community. There's also lots of information on various physical activities that we run all around the country. If you like tuning into things like webinars, we also have a podcast series that you can listen to, and that's been running for 4 years now. So we have a whole range of episodes on a big range of topics for you to listen to. And as well as then video interviews that we've undertaken over the past number of years as well on a whole range of topics with specialist speakers. And of course, we also have blogs. So there's lots of information, lots of things that you can find on our website. If you need any information or practical support, we have a free national helpline, and that's open Monday to Friday, 10 a.m. to 4 p.m. And the number is there, it's 0818 252 846. And then you will get through to one of our trained peers who will help you with your query. One of the things, given that the focus is on women and arthritis, I just wanted to give a special mention to the VHI Women's Mini Marathon and all of the women that are undertaking this event during the June Bank Holiday weekend. Just to shout out that if you would like to support Team Arthritis Ireland by donating to all of the amazing women who are running or walking it on our behalf, every step they take and every euro you give helps improve the lives of people with arthritis. So you can scan the QR code or log on to our website if you'd like to make a donation. And then I'll move on to just a few housekeeping things before I hand over to Professor Gráinne Murphy. So just to say that this webinar is being recorded. And it'll be available to view on our YouTube channel after the event. Okay. Just everybody but the speakers and presenters are on mute, and all the cameras are off as well. So that's the way in which we set up the webinar. If you have a question, we'll have 15 minutes allocated at the end for Q&A. And what we'd like you to do is, if you look along the ribbon there on your screen, you'll see a Q&A function. We'd like you to put your question in there. So if you have a question for Professor Gráinne Murphy, please put your question in there and we will go through them as we move through the webinar. And we will do our best to respond to as many questions as possible within the time frame. Okay, so without further ado, I am going to pass you over now to Professor Gráinne Murphy. And thank you, Professor Murphy, for joining us this evening. Delighted to have you. You're very welcome.
Thanks very much, Gráinne. I'm just going to bring up my presentation. And thanks to everybody for joining us on this beautiful. Perfect. And again, as I say, thanks to everybody for joining us on this very beautiful May evening, during which time hopefully I'm going to get to talk to you about a number of different aspects and challenges, I suppose, that we frequently come across in dealing with conditions, rheumatic disease, but particularly in relation to women's health. So what we're going to go through this evening, we're going to try and understand a little bit more about the differential prevalence of rheumatic diseases, particularly autoimmune rheumatic diseases in women, and discuss some aspects of the physical, the mental, and the emotional impact that may have. And then we're going to briefly touch on and explore challenges that may occur at different stages of a woman's life cycle, which are of particular relevance to these conditions, but bearing in mind that a number of these, I suppose, challenges or the aspects of this will be covered in later webinars by some of my colleagues. And then I'm going to try and touch on a number of aspects of both current management, but also prevention strategies at different levels. So autoimmune diseases are diseases where the host's immune system mistakenly, for want of a better word, attacks itself. It's when the immune system starts to run awry, for want of a better word. And there's a number of different immune-mediated rheumatic disease, many of which have the common thread of being more prevalent in women. So we quite often, and I suppose most people are aware of some of the more common conditions that we foresee as rheumatologists. And these include rheumatoid arthritis, SLE, psoriatic arthritis, and spondyloarthropathy. And as you can see on the graph on the right-hand side, a number of these are very much disproportionately affected, more prevalent in women. And the prototypic of these is lupus, where there's a 9-to-1 incidence in females to males, but other conditions such as Sjogren's syndrome have a very similar female preponderance. In fact, there are very few autoimmune diseases which are more prevalent in men, the exceptions to this being diabetes or ulcerative colitis, which have a somewhat more equal prevalence. And in terms of rheumatology, inflammatory spondyloarthropathy has, again, probably a roughly equal prevalence, but it is understudied in the female population. And this is perhaps more markedly so at particular times of a woman's life cycle, particularly during the reproductive years, which has led to a number of theories as to how this might transpire. So I'm going to touch briefly on how and why I suppose there may be differences in terms of gender incidence in disease. And we might just talk a little bit in terms of severity for some of the more common conditions. So it's not just one mechanism which leads to the differential incidence of disease in women compared to men. And each disease is somewhat different in terms of how the immune system is both activated and how gender may play a role. The most obvious difference between men and women is the chromosomal differences, the fact that women have 2 copies of an X chromosome, whereas men only have 1. This is more complex than we may, I suppose, at first glance understand, because in women, 1 copy of the X chromosome is inactivated at a cellular level. But scientists have come to realize that some of the genes present on the X chromosome can be active despite the theoretical inactivation which occurs at a cellular level. And interestingly, X chromosomes contain more genes which are of relevance to the immune system, genes which both activate the immune system and genes which regulate the immune system. This is also coupled with the fact that there are significant different hormone profiles between men and women. And I suppose to that end, we're perhaps most aware of the differential levels of estrogen and progesterone, but also testosterone in women. Estrogen and progesterone are present at clearly much higher levels and are present on the majority of immune cells within the body, and clearly lead to a differential effect given the higher levels that we see in women, and particularly at certain times of a woman's life cycle where these levels fluctuate. Estrogen and progesterone tend to have more pro-inflammatory roles, whereas testosterone, which is obviously the more predominant male hormone, tends to have a immunoprotective role. But hormones and chromosomes are not the only answer. Women and men differ in other aspects, particularly environmental triggers or environmental exposures. For example, in some of the conditions that we see, such as scleroderma, there seems to be a significant chemical contribution in men who are exposed. The majority of men who have been diagnosed with scleroderma have been exposed to chemicals such as silica or perhaps pesticides, but we know that there are other environmental exposures that are more common to the gender, such as sunlight and vitamin D. And all of these, both genetic and epigenetic aspects, leads to complex effects within the immune system, which ultimately leads to disease expression. It becomes somewhat more complicated, however, when we look at disease severity. So although in conditions like lupus, where there's a significantly greater number of women affected, the disease, when present in a man, tends to be more severe. This is also the case with other conditions such as autoimmune hepatitis, and the converse is true for immune-mediated diseases such as Crohn's disease, which is more severe in young females and tends to be exacerbated during periods of hormonal fluctuations such as in pregnancy. This slide is there not to confuse matters because it's a very complicated slide which delineates the effects that estrogen has on the immune system. All of these cells are involved to some extent in the common autoimmune rheumatic diseases that we see, and all of them are affected by estrogen. The majority of the effects of estrogen in these conditions are to increase the prevalence and to I suppose, modulate the effect and disease severity at times of changes in hormone levels, particularly during menarche and when a female starts to get periods, during pregnancy, and later on in menopause when the effects of estrogen dwindle and decline. So I'm going to go through some of the more common immune-mediated rheumatic disease conditions which you may be familiar with or may have a diagnosis of. The first is rheumatoid arthritis, which is one of the most common inflammatory arthritis in the country and internationally. It's been said to affect 1% of the population, and it presents as an inflammatory arthritis that causes and leads to pain, swelling, stiffness, and potentially joint deformities. It does differ within the genders in that women, again, make up the majority, up to 70% of cases, and women tend to present earlier than men with this condition, often presenting during reproductive years in their 30s or 40s. And again, as you can see on the graph on the right, men tend to have a later peak, anything up to the age of, or the age category group between 60 and 80. There's conflicting information, however, on the effect of gender on disease severity, where most reports will document that women and men likely have a similar disease severity, but they suffer differently when it comes to complications. Perhaps because of the inherently greater risk of cardiovascular disease, men tend to have more frequent cardiovascular disease, whereas again, women who are predisposed to osteoporosis, when faced with the combination with rheumatoid arthritis, have a greater rate of bone-related complications, including osteoporosis. It's very important to bear in mind not just the direct effect on joints, however, with RA, and many studies have shown and documented that women with RA have a higher prevalence of depression and also anxiety, and additionally that women with RA have higher rates of health-related disability due to both higher rates of mental health disorders, but also due to the effects of their condition directly on their joints and higher levels of pain. And this ultimately can transpire as lower levels of physical function. Second condition which I'd like to go through is that of lupus, which is a condition which I have a particular interest in. As I mentioned earlier, SLE has a very strong female preponderance, affecting females to males in a 9-to-1 ratio in the reproductive age. It's a multi-system condition, and what this means is that it can affect multiple organs, but that its manifestations between different individuals can be very different. To that end, certain patients who have lupus would present mainly with a rash or perhaps with joint symptoms such as pain, but others can have more multi-system disease, where lupus nephritis or inflammation in the kidneys, or indeed CNS involvement, which can present in a number of different ways, leads to flare-ups and can have a significant impact on quality of life, but also the need for long-term immunosuppressive medication. The gender differences in the rates of lupus are less prominent when in childhood and in older onset SLE, and this likely reflects a number of different factors, but particularly the effect of hormones, which are more similar between the genders, either in childhood onset lupus or in women and men after the age of 50 years. Interestingly, when lupus does develop in those groups, either early or later onset, it tends to be more severe, and men tend to have a worse outcome with more kidney involvement, and interestingly tend to have less skin involvement and less articular or joint symptoms. Lupus is particularly challenging when it comes to pregnancy and menopause because there is a very strong link between exogenous estrogens or internal hormonal fluctuations and their effect on disease flare-up or disease severity, and we'll come to that a little bit later in tonight's talk. I also want to mention the spondyloarthropathies because it's an area where there's increased interest and increasing information, particularly in relation to comparison of the gender distribution in terms of incidence, but also how it affects individual patients. So this is a long and complicated term, but essentially means inflammatory arthritis that affects the spine, the sacroiliac joints, which were at the base of the spine, and peripheral joints, most commonly knees, hips, but can affect small joints also. It's not uncommon with this particular condition to have involvement outside of the joints, and this can include inflammation in the eye, it can include psoriasis, it can include inflammatory bowel disease. And interestingly, previous studies would have shown that men had much greater incidence of spondyloarthropathy, but we now know that this is because women tend to present with subtler symptoms. Many have gone underdiagnosed, and this can quite often lead to a delayed diagnosis. There are genetic tests which are supportive, and that's a HLA-B27 tests. And in women, it can present differently. So to that end, in terms of the presentation, this condition also tends to lead to inflammation in the joints of the spine, which leads to restriction in spinal mobility. Women tend to have greater underlying mobility within the spine. And with a normal examination, many women with inflammatory back pain may be discounted initially, and this might not be considered. So it's very important to bear in mind the inherent differences between the genders when making a diagnosis. As I mentioned, it has a likely equal prevalence with men as we increase our understanding of the condition. And because of the historic underdiagnosis, women have been underrepresented in therapeutic clinical trials. They often face greater diagnostic delay and tend to have a lower probability of remission and a lesser response to biologic drugs, and tend to have a higher BMI with a lower level of systemic inflammation as we measure with a blood test called a CRP test. Again, this is a somewhat complicated slide. I just want to draw your attention to the fact that women and men are different with spondyloarthropathies in how they respond to therapy. So this slide refers to the other complaints outside of the joints and how they respond to treatment in this group of diseases. So men tend to have a poor response in terms of psoriasis when present, and women tend to have a poor response in terms of pain, the amount of tender joints, and their functional scores. And these functional scores are represented in the graphic on the right of the screen, where you'll see that multiple studies have shown that women do poorly, and these are the pink dots, reflected across a number of domains which are relevant, including anxiety, depression, fatigue, pain, and again, different scores and metrics of physical function. I also wanted to mention fibromyalgia, which isn't itself an autoimmune condition. It is a very common chronic pain condition which affects muscles and soft tissues, and it not only leads to pain, but it also leads to a number of other comorbidities, including what can be debilitating fatigue and cognitive issues, most commonly described as brain fog. The vast majority of cases are described in women. And it's important to bear in mind as it's common in patients who have underlying inflammatory disease and if not recognized and managed appropriately can lead to either excessive treatment or perhaps poorer understanding of presenting symptomatology. So we've reviewed the common autoimmune rheumatic disease, and it's clear that women have a greater incidence than men. It's important to remember, however, that both as doctors and patients, that the effect of such a diagnosis can often have less visible effects on people. It can be easier on occasion to focus on the physical manifestations and how we can treat them, but we must bear in mind the other consequences of a chronic disease, particularly autoimmune diseases. And this can affect a number of aspects of quality of life. The first, and I mentioned perhaps the most obvious, is physical health. Chronic pain, limited mobility can result either as a consequence of undertreated disease or a consequence of damage which has gone before. And pain is not always visible. We must remember to inquire about pain, and as patients, to voice your concerns about pain. Pain can also couple with fatigue and joint deformity to impair quality of life. And from a comorbidity point of view, chronic autoimmune diseases can lead to increased risk of cardiovascular disease and osteoporosis, which should be screened for and awareness increased. The second aspect in terms of quality of life and how disease can affect patients who have chronic autoimmune rheumatic disease is that of its effect on mental health. This is complex, but women certainly outscore men both in the incidence of depression and anxiety across numerous clinical trials across all of the autoimmune rheumatic diseases which I have described. This can in part be explained by chronic pain, by poor sleep, but also the effects of a chronic disease, the chronic medication requirements, and this can lead to mental health struggles. This needs to be treated with support, be that organizations such as Arthritis Ireland, engaging with colleagues, engaging with other support groups, and also by primary care input with either psychology or occasionally medication. But first of all, we need to recognize it. The last aspect that I wanted to mention is the effects on quality of life. And it's important to bear in mind that in society, women still have different roles to men. The quality of life can be impaired both at a physical level, but also from a mental health perspective, and this can have effect on performing everyday tasks, such as working, caring for families, caring for young children with the physical effects of an autoimmune rheumatic disease with painful joints, tasks such as changing a baby's nappy, providing bottles, breastfeeding. They can all be difficult and certainly more challenging in the context of a long-standing condition. I mentioned that it's important to inquire about them, but we also need to measure them. And I've just decided to highlight a number of the patient-related outcome measures that are available. They are available in routine clinical practice, but are not always measured. They're becoming increasingly and frequently used as outcome measures in clinical trials. For clinical trials, it's very important that patients have a role to play. And there has been increased recognition of this, and regulatory authorities who sanction the use and approval of new drugs now recognize patient-related outcome measures as very valid and important aspects of approving a new therapy in a condition, and including conditions such as SLE and RA. The measure on the left is the SF36, which looks at a number of domains of physical function. And the facet scale on your right is a measure of fatigue. The HAD score is commonly used in clinical practice as a very brief but very helpful tool to pick up subclinical anxiety and depression. What's important to bear in mind, there are a number of gender differences in these patient-related outcome measures, and this likely represents a number of different factors. So in many, many clinical trials, it's been shown that women score poorly on anxiety and depression scale. They also score more highly on fatigue and have lower levels of physical function. And there are a number of different theories behind this. This should say men rather than women. So it's been theorized that perhaps men underreport aspects of their condition, such as its effect on their mental health due to perhaps underlying stigma, and at a physical level that they have a greater compensation in the physical domains due to their inherent higher muscle mass and their lower prevalence of bone-related complications such as osteoporosis. I mention this because it's important in terms of therapy. A tailored treatment plan is recommended and should include holistic management and care of patients. I've included this diagram because it's important to bear in mind that treatment of rheumatic disease is not just medication. It should be and must be holistic. This diagram serves to remind us that wellness differs from comorbidity control, it differs from health promotion strategies, and in order to achieve optimal health, in addition to treating to target and to getting what us physicians may consider low disease activity, we must consider the effects that a condition has on other aspects of a patient's life. And therefore, we must bear in mind the effect of physical modalities such as exercise. We know that up to 80% of patients with a chronic immune-mediated condition have limitation on physical function, and therefore you need engagement with modalities such as physical therapy or physiotherapy can help to find a tailored exercise program which is suitable for patients. It's important to bear in mind that there are other avenues such as occupational therapy, which may help with other aspects of physical function, but can also provide advice in terms of fatigue and in terms of sleep. I mentioned the effects on mental health, and this is where a psychologist or perhaps a primary care physician may have a role to play in dealing with the effects that a chronic autoimmune condition may have in that regard. There are a number of other different aspects of disease which should be addressed also, including nutrition, social connectedness, and emotional support. Now, I wanted to bring up the challenges, and this is a very brief slide, but just in terms of the challenges that there may be, and that may be relevant in terms of gender predilection or the differences that different genders may present in terms of diagnostic delay. So this is evident perhaps in certain conditions more than others, and this may be due to that women's symptoms may be more subtle, or there may be biological differences which influence a clinical exam. And we mentioned that in a spondyloarthropathy, women's greater inherent mobility, particularly in the spine, may lead to a later diagnosis because physical examination can be normal. Other conditions can also lead to delayed diagnosis because their early symptoms are subtle. And these are conditions like RA and lupus, but also Sjogren's syndrome, where it can take time to have a more full manifestation of symptoms. And this leads to greater diagnostic delay but as these conditions are more prevalent in women, affects women disproportionately. Historically, there were gender biases in healthcare, which not only led to underestimation of women's pain, but previous studies in the arena of RA led to later diagnoses because women's pain and their symptoms were underestimated. And this has been resolved with a more recent study demonstrating that women and men are seen at a similar presenting time, certainly in the arena, or certainly in the disease area of RA. I also mentioned that there has been historic underrepresentation in clinical trials, an element of gender discrepancy which has been addressed, and we are now seeing, I suppose, a more equal representation of genders in clinical trials of AxSpA or spondyloarthropathy, and hope that this will continue going forward. So we're going to just change tack now and look at a number of different, I suppose, time frames within a woman's life where the presentation or complications of their condition may have greater relevance or may need greater input. Women have fluctuating hormonal levels throughout development, from a baby to teenage to pregnancy to menopause, and face similar challenges with aging, immunosenescence and inflammation, which is a more recent term which has been coined. So we're going to go through each of these, but I just want to emphasize that these will be covered in far greater detail by my colleagues over the upcoming webinar series. So one of the first aspects that I wanted to touch on was that of contraception. And this is important for a number of different reasons. One of the aspects of autoimmune diseases in pregnancy is that many studies have shown that in order for a pregnancy to have the best chance of success, be it from miscarriage outcome or looking at a more holistic view of pregnancy and looking at rates of small babies, the presence of preeclampsia in women or other pregnancy-related complications, entering the pregnancy at a state of low disease activity is essential. And pregnancy in the context of a chronic autoimmune condition, be it a rheumatological condition or a gastroenterological condition or a neurological condition, is imperative. And this should be planned with both your specialist, with the primary care, and also with the input of an obstetrician. And in order to achieve a planned pregnancy, contraception is something that we must frequently inquire about and discuss with patients. We know that many studies have shown that this is not always the case, that women do not always take what is prescribed in terms of contraception. And this could be because the contraception which is prescribed is not acceptable or has an unacceptable safety profile. And it's very important that this is a two-way conversation to find a method of contraception that is effective and acceptable for patients. In general, longer-acting forms are most reliable. But there are a number of different guidelines which we can use to help us in that decision-making process. This is a very complicated slide, but it's just to emphasize that physicians are guided by guidelines. And there are a number of different guidelines. I'm referring here to the American College of Rheumatology and the very comprehensive guidelines that they've provided in terms of contraception. There are a number of different contraceptives which need to be avoided with particular clinical scenarios. And that is particularly true for estrogen-related contraception, which generally should be avoided in people who have a pro-clotting condition, which can complicate immune-mediated diseases. And this can be picked up by an antiphospholipid test, which has a number of different antibody tests, which is ordered routinely at clinic, particularly for people who have underlying SLE. The other scenario where we, at least historically, would have considered estrogen-containing contraception to be problematic is that in lupus, because of the direct influence estrogen has on lupus activity. We now know, however, that estrogen really has an effect only in people who have underlying moderate to severe disease activity, where we would avoid estrogen, but may be tolerable and safe in people who have low disease activity without a history of clotting, who don't have high levels of protein in their urine. In general, we do like the longer-acting progesterone methods of contraception because they are effective, because they're long-acting, and because they don't have estrogen. And this particularly is relevant, I suppose, for the coil or the implant. One special scenario that just to highlight is that certain medications require two types of contraception or an introductory device, and this is particularly so for a medication called mycophenolate, which is directly harmful to a fetus. The next, I suppose, step in a woman's life cycle where extra or additional input is required due to the changes at that time is pregnancy. And we can look at this as a two-way flow between the impact of the condition of pregnancy and the impact of the pregnancy on the condition. In autoimmune diseases, for particularly a number of them, and I'll come to this on my next slide, there's an increased risk of complications. And this includes preterm birth, miscarriage, and preeclampsia. But this is particularly and predominantly true when people enter pregnancy at a time of poor disease control. Some conditions go into a longer extended remission during pregnancy, but can flare up after pregnancy. And as I mentioned, planning a pregnancy at a time of controlled disease, therefore, is essential. It's very important that care for patients during pregnancy is coordinated between rheumatologists and obstetricians, and that at that time and prior to pregnancy that we use safe medications that are compatible with pregnancy to control disease activity. There are a number of preventive strategies that we use also, medicines that reduce the risk of harmful effects to the baby or the mother, such as using aspirin at higher doses than previously, or medication like hydroxychloroquine when there are certain antibodies present in the mother's blood. And postpartum, it's very important that women be followed up closely because there is an increased risk of flare-ups due to the rapid hormonal changes present at this time. I mentioned that different conditions respond differently to pregnancy. In rheumatoid arthritis, historically, we would have documented that the majority of people would go into a long-term remission. We now know that that's not the case, but the majority of patients do improve on therapy during pregnancy, but there's still a 20 to 30% flare rate, whereas there is a very high flare rate in the postpartum period. Patients with SLE have a greater rate of flare, as high as 30%, even when disease is controlled at conception. But this is particularly true when lupus affects the kidneys, and again, a high postpartum flare rate. With other conditions such as psoriatic arthritis, the majority improve, but again flare after having delivery. And with the spondyloarthropathy, we now recognize that this is a common condition to flare in pregnancy, particularly in the second trimester, where flare rates are as high as 25 to 50%. My general advice for pregnancy, and these are very, I suppose, brief bullet points, but points that I would like to emphasize, are to plan pregnancy when the underlying rheumatic condition is well controlled, to use safe medication, to not be afraid and to continue hydroxychloroquine if Ro antibodies are present, because there is very good data that this is effective. Low dose aspirin, but at higher doses than previously. No smoking. Folic acid, both when planning for pregnancy, but also during pregnancy and at higher doses if taking a medicine called slazopirin. And that to know that there are very excellent resources available, both to patients and physicians, particularly the BUMPS website, which gives excellent information for medication safety. And we also now have our own HSE guidelines for planning and managing pregnancy in the setting of autoimmune rheumatic disease. And this highlights the need for both preconception advice, but also combined care both throughout pregnancy with close rheumatic follow-up in the postpartum period. So this slide I've included because I just wanted to emphasize that sometimes patients, and I've certainly seen it myself in clinical practice, we're in an arena where we are very fortunate that we have greater access to assisted reproductive technology and IVF. And historically, patients would have been, I suppose, somewhat fearful of the effects of stimulation, of egg harvesting, of the hormonal input that is needed in order to achieve AOT. But again, there are guidelines to help us in this regard, and there are very few clinical instances where this would not be possible or compatible, other than to say that if a patient has underlying moderate or severe disease activity, to defer assisted reproductive technology, not consider it, but defer it to a time when disease is better controlled. Sometimes people would need support in terms of a change in medication, or they may need preventive blood thinners in order to assist and to make it safer to proceed. But it's certainly something that needs to be discussed, both with your rheumatologist and also with an obstetrician and occasionally a hematologist. The next stage in a woman's life cycle that needs to be emphasized, and again, I think it's a very topical area, but for a very good reason, is that of menopause. So menopause is the permanent cessation of periods when they have been absent for over 12 months without an underlying biological cause. But it's certainly not just a single period of time. Hormonal fluctuation leading up to the last regular period and in the number of years thereafter not only has effects on the menstrual cycle, but also has an effect on other aspects of a woman's life. We know that in a menopause that's not complicated by an autoimmune rheumatic disease, pain and stiffness are common. There's changes to mental health, changes to sleep, changes to circulation, And this is likely mediated, at least in part, by the rapid changes in hormone profiles. So as you can see in the graphical representation down here on the right, that hormone levels fluctuate quite significantly during the menopausal period, and the previous pro-inflammatory estrogen levels to start to decline, progesterone starts to decline, and the levels of gonadotropins, or FSH and LH, which are sometimes used and requested by GPs to confirm the chemical aspect of menopause, they tend to they elevate after menopause. So the mentioned menopause is not just relevant in terms of cessation of periods, but also has a number of different other effects, which should be discussed, but should also be managed and managed appropriately in women. And this is not just true for those with underlying autoimmune rheumatic disease, but we know that perimenopausal women start to have imbalances in sex hormones, including estrogen and progesterone, and this leads to its complex effects on the immune system, can lead to increased inflammation, does lead to altered metabolism, which can result in weight gain, and can lead to psychological changes, not only due to the hormonal fluctuations, but also due to the accompanying metabolic disease, sexual dysfunction, and musculoskeletal symptoms, which can occur at this time. I've included the diagram on the right to remind us that menopause itself can be a direct cause of joint pain, even when the underlying rheumatic disease is well controlled. And again, there are multifaceted reasons for this, not only the direct effect of estrogen and progesterone on the receptors within the soft tissue in and around the bone, but also menopause leads to trouble sleeping, which has consequences on pain and how our brains perceive pain. It can lead directly to changes in mood, and again, increased nociceptive pain pathways within the brain can lead to weight gain, which in itself can lead to increased pain, particularly in the back and lower limbs. It can also, and has been shown to be associated with an increased prevalence of osteoarthritis and arthritis, and certain autoimmune conditions are diagnosed more often in the perimenopausal years, such as rheumatoid arthritis. So in terms of menopause and how it affects the underlying rheumatic disease, again, it's complex depending on the underlying condition. So it can worsen existing rheumatic disease or can increase the risk of developing a new rheumatic disease such as RA. This is due to both the estrogen decline, which directly leads to increased inflammation or joint pain, an increase in RA symptomatology particularly, which can worsen during or after the menopause, and complications such as osteoporosis, significant increase post-menopause. And then again, just harping back to my previous slides in terms of the more common autoimmune diseases. So rheumatoid arthritis, as I mentioned, has an increased incidence after the menopause, particularly in women actually who have an early menopause. And existing rheumatoid arthritis can worsen post-menopause. HRT has been shown perhaps to modulate the effect of menopause on RA activity. And interestingly, there is some data to suggest that HRT may be preventive in women who have an underlying antibody, which puts them at risk for RA, and that's anti-CCP antibodies. Lupus is somewhat converse in that flare rates of lupus can decrease in the postmenopausal period, but damage, particularly vascular complications, increase due to an increased risk of cardiovascular disease. HRT can be used in lupus, but must be used with caution due to the clotting risk. And osteoporosis and bone loss across the board of the autoimmune rheumatic diseases, there's an increased prevalence in the postmenopausal period, and up to 30% of postmenopausal women with rheumatoid arthritis can develop osteoporosis. This is direct consequences, I suppose, on how we manage patients in the perimenopausal region. We have to be more cognizant of the increased osteoporosis risk, and DEXA scans can be very helpful if they're done on a routine basis. But particularly looking at fracture risk, and we use particular tools such as the FRAX score for this. We should not discount HRT. There are very few women with who have a complete and absolute contraindication of HRT, and there are clinics, particularly complex menopause clinics, regionally at least, which may be warranted for select high-risk cases. And we should tailor our treatment strategies to manage the accompanying pain, inflammation, in addition to effects on bone density that menopause can bring. Again, going back to the ACR guidelines, certainly just to, I suppose, to highlight that HRT is, again, very rarely absolutely contraindicated, and this is really in a condition on the left, again, antiphospholipid syndrome, which is a pro-clotting condition more common in people who have SLE. But for non-autoimmune rheumatic, non-SLE rheumatic diseases, HRT is usually recommended if needed. And for lupus, certainly with low disease activity, there is only a mild to moderate risk of SLE flare in the context of HRT if their risk is low of clotting. This slide, I suppose, documents the risks within different conditions of flare in the menopausal period. So menopause has a direct effect on RA incidence, but also severity, as I mentioned. Psoriatic arthritis does not tend to have an effect, actually, menopause in the postmenopausal period, either in terms of incidence or severity. Lupus, the gender discrepancy in terms of incidence is reduced, and women who enter menopause who have underlying lupus tend to have an improved disease activity and decreased frequency of flare. Sjogren's syndrome, again, it's a complex clinical scenario, but estrogens seem to have a protective effect on salivary gland function, and postmenopausal, there is an increased risk of the dryness symptoms that patients encounter who have Sjogren's. And systemic sclerosis tends actually to see somewhat of an improvement, particularly in skin fibrosis, but may have an increased risk of developing complications, particularly in those with a limited form of disease. So in the last 5 minutes, I just wanted to talk a little bit about prevention of autoimmune rheumatic diseases. Prevention is a very complicated topic in that we're only, I suppose, increasing our understanding of the very complex immune mechanisms that lie behind autoimmune rheumatic diseases. And there are certainly modifiable risks in addition to what we would see as non-modifiable, and clearly aspects of an individual patient's risk, such as genetics, are non-modifiable, where family history is certainly a risk factor for autoimmune diseases and is perhaps more relevant in certain conditions than other. Gender is a further non-modifiable risk, as is age, and that many autoimmune diseases develop between ages 15 to 45, but certain, such as RA, develop later. And ethnicity is a certain non-modifiable risk factor, where certain groups tend to be more affected or have more severe disease. For example, African American or Hispanic women have a higher risk of lupus and have increased disease severity. But we shouldn't underestimate the modifiable risks, and there are many of these which we can be proactive, both women and men, in terms of reducing our risk of developing an autoimmune rheumatic disease. And the modifiable risks are smoking, obesity. There's some very interesting data coming through on diet and the gut microbiome, the effects of chronic stress on the immune system, and exposure to environmental toxins that I mentioned earlier, certain chemicals which increase the incidence of conditions such as scleroderma, where silica has been shown to have quite a strong link. We can also look at prevention as primary, secondary, tertiary prevention. And primary prevention means preventing a disease in someone who's not in an at-risk state, who is otherwise healthy. And first and foremost, avoiding smoking. Avoiding smoking is particularly important for rheumatoid arthritis. It is strongly linked to rheumatoid arthritis, particularly in people who have genetic predisposition. And smoking cessation reduces both the risk, but it also improves response to treatment in patients who have RA and reduces the risk of interstitial lung disease. In people who have established disease, smoking also reduces the chances of biologic and non-biologic therapies working, such as hydroxychloroquine in lupus. The second aspect of health promotion or primary prevention that I wanted to touch on was a healthy weight. And that not only has direct effects on pain, because increased BMI leads to increased rates of pain, particularly, as I mentioned, in the back and lower limbs due to increased rates of osteoarthritis. But obesity itself is a reservoir of systemic inflammation due to high levels of estrogen and the products that it is converted to. And this can lead to both an increased risk of autoimmune disease, but can also reduce the chance of responding to treatment. And that's because fat tissue produces cytokines that lead to complex effects on your immune system. So not smoking and maintaining a healthy weight are very good aspects, are very good general health recommendations, but can have a direct consequence in preventing disease. There's very interesting data in terms of anti-inflammatory diets in autoimmune rheumatic disease, but also in prevention. And the most evidence comes in the form of the Mediterranean diet, which is rich in omega-3s, vegetables, fruits, whole grains, and particularly antioxidants. And that's been shown to potentially reduce inflammation and to support immune health. Vitamin D is very topical and has been for many years. We know that low vitamin D levels are associated with an increased prevalence of many autoimmune conditions, such as rheumatoid arthritis, MS, and lupus. And supplementation may reduce the risks, so the data on this is a little less clear. Vitamin D insufficiency is very common, particularly in northern latitudes. With current weather accepted, we tend to see less sunshine than other latitudes. Limiting environmental exposure to chemicals and pesticides, heavy metals can be important. Some are linked more strongly than others to autoimmune rheumatic disease. And this can be relevant for particular occupations where it's recommended to use PPE if working in high-risk environments. As I mentioned, it's particularly men that I've seen with industrial chemicals and pesticides who have developed autoimmune diseases, and particularly scleroderma. Managing chronic stress can be somewhat more challenging, and that is because we live in a society with high levels of stimulation and high demands. And long-term stress has been shown to disrupt immune balance, and long-term stress has been shown to have effects on existing rheumatic diseases such as lupus, where it can increase flare rates. It can be difficult to achieve, but we're not without hope. There are a number of different avenues that people can explore, including mindfulness, cognitive behavioral therapy, yoga, and managing things such as adequate sleep to help, and exercise to help regulate immune responses can be helpful in prevention. Secondary prevention refers to preventing immune-mediated rheumatic disease in a group who's already at risk. And that can be individuals with a strong family history of autoimmune disease, or who have early warning signs such as joint pain without swelling or fatigue with perhaps antibodies. And patients should be educated in terms of what symptoms to be mindful of and should be monitored regularly. And all of the components that I mentioned in primary prevention should be emphasized here, with the addition of things such as vaccination and infection prevention. We know that certain infections, particularly things such as Epstein-Barr virus, which causes glandular fever, but other infections also can trigger autoimmune activity. And we know that there are very effective vaccines for certain viruses, which reduces infection risks and therefore can reduce the impact that may have on the immune system, and perhaps reduce the risk of new onset autoimmune diseases. Tertiary prevention refers really to once an autoimmune disease is diagnosed, and the goal of this is to prevent flares, to reduce organ damage, improve quality of life. And a number of different strategies, again, coming back to the primary prevention strategies that I mentioned, but also early aggressive treatment with DMARDs, consistent follow-up with specialists, lifestyle modifications, including nutrition, sleep, and exercise to support systemic health, and patient education, psychosocial support, and support groups such as Arthritis Ireland can be essential. It's also important from a patient perspective to be an advocate for your own health, to bear in mind that because some of these conditions increase complications such as cardiovascular risk, to have your blood pressure checked, to know that there are cardiovascular risk scores which can pick up an increased risk state before cardiovascular disease develops, to know that exercise is important, but you might need a modification in your exercise program. Be mindful of things like bone health and increased rates of osteoporosis, and again, smoking prevention or cessation. There's some interesting data on gut microbiome. We know that there are altered gut flora between men that differ between men and women, and certain conditions have higher rates of what we call dysbiosis, or abnormal rates of different bugs within the gut, and that supplementing with probiotics and perhaps dietary fiber may help modulate this. And there's some very interesting data coming through as well on how lifestyle might impact gene expression. We don't know yet how this will translate into disease prevention or management. So just to conclude, women are more predisposed to autoimmune rheumatic diseases than men, but the patterns of disease differ, as does the severity and the impact of gender on disease expression. We know that there are a number of different times within a woman's life cycle where certain challenges are encountered and need support, both from a medical but also more holistic perspective, and that for people who have underlying rheumatic disease, that a multimodal treatment strategy, bearing in mind the physical, emotional, and medical impacts of disease, should be considered. There are a number of different resources available to patients, both online and by way of support groups. And from a patient perspective, just to bear in mind to be an advocate for your own health in terms of aspects such as cardiovascular and bone health. And with that, I'm going to finish my presentation, but I'm very happy to answer any questions that you might have.
Thank you so much, Gráinne. That was just hugely informative. So thank you for giving your time. I know my colleague Tara has been monitoring the questions, so there are some questions to put to you. So I'm going to hand over to Tara.
Thanks so much, and thanks again, Gráinne, as well. That was, as Gráinne said, really informative. So we have some questions here. Actually, one question that I had that we had received a query about before was about the biological differences between men and women. So does that influence the treatment approach to arthritis itself then, if there's, different, obviously, genders? Is that something that's taken into consideration with treatment?
So in terms of studies, we know overall that for certain conditions like spondyloarthropathy, or that condition that causes spinal inflammation, that women respond more poorly than men, but they haven't shown that for particular medications. So as yet, we don't have a tailored treatment strategy in that, I suppose, in that sense. For many of the autoimmune rheumatic conditions, we're constantly looking for biomarkers, and I suppose gender can be a biomarker, but we don't have that data as yet to show that women will respond better to a particular biologic than their male counterparts. So currently, the treatment strategies are very similar, other than to say that depending on, we'll say, the aspects like family planning, we may choose one drug over another.
That makes sense. Great, thank you. So we have a question here about sunlight exposure, and there's a query as to whether or not that can trigger autoimmune disorders. Is that true, or is there any basis to that?
So certainly for lupus and for Sjogren's, people who have certain antibodies with Sjogren's and with lupus have a greater incidence of flare, or can have a greater incidence of flare. So roughly 2/3 of people with lupus are what we'd call sun sensitive, or sensitive to UV light. So UV light can have a direct effect on the cells within your skin, and that can lead to either a rash, or in some people it can actually cause a flare of their underlying disease in general. So we're very mindful, I suppose, with conditions like lupus, or as I mentioned, Sjogren's with particular antibodies, to tell people to use sun avoidance strategies. But saying that, I think it should be emphasized as well that sunlight has direct effects on everybody. So it's really important that some of our biologic drugs, or some of the other drugs that we use, and the effects they have on the immune system, can increase the rates of particular type of skin cancers. So it's really good general advice to educate our patients on sunlight protection, to use factor 50 to avoid the sun, to wear a hat, to cover up. And I know it's glorious outside at the moment and it's hard to hear that, but frequent reapplication of sun factor and covering up it is important advice for everybody, but just particularly true for certain conditions.
Okay, that's it. And there's a question here, and I think it's a really important one, seeing as you mentioned it quite frequently. Is there, how do women request a bone scan for osteoporosis?
So for the most part, it's through their primary care provider. There are an increasing number of centres around the country which offer bone density assessments. They're available publicly and privately. I would say that one of the things, I suppose, that there's increased information about is when you get back your bone density result, what to do with it. So you'll often find on a bone density result now that it doesn't just say what we call your T-score, or your level of, I suppose, bone health, but it also tells you a fracture score. And actually, that's the most important part of information to take from it. We know that in terms of treating, and by treating, I suppose I mean medicines other than calcium, vitamin D, exercise therapy, physiotherapy, etc., and resistance training. But if we were going to use another medicine, it really depends on your fracture risk rather than your exact bone density. And it's really important whether to know whether someone has fractured or not. So there's loads of different avenues of getting your bone density assessment. But if you were worried, I'd say start with your primary care provider, your GP usually. And then for people who have existing rheumatic diseases, we often order them through the rheumatology service.
So there's a lady here who says that she's 53 and has a 3-year history of stiffness, muscle and joint pain, fatigue. Is HLA-B27 positive, but no other positive bloods, x-rays or MRIs, and HRT has not helped. So they're seeing the doctors, getting no diagnosis and no treatment. Is there anything that they can do, or any suggestions for them?
So I suppose HLA-B27 is a genetic marker in the blood, and it's a marker that's present in 8 to 10% of the population, and 1 in 10 of those people may then develop an autoimmune disease. It's usually a kind of spondyloarthropathy. It's complicated though, when that, the majority of people who have HLA-B27 positive don't have an underlying autoimmune rheumatic disease, but with the symptoms that you report, if you have pain and stiffness that hasn't improved with HRT therapy, it's certainly worth having a second opinion. I don't know from the question whether or not they've seen a rheumatologist or not. And I suppose it's really important to check whether, you've got a stiff back. So if your back is very stiff, particularly if it's taking hours in the morning to loosen out, it might be interesting to have imaging of that area. As I mentioned, women with spondyloarthropathies, they usually get diagnosed later. Because symptoms are a little bit more indolent, a little bit more subtle. So it sounds like that individual might need an assessment by a rheumatologist.
Thank you. We have another question here about whether or not it's worth getting a microbiome test and if there's a way of getting a recommended service for that in Ireland. I'm not sure.
So that's, I suppose that's still controversial. There's loads of interesting studies ongoing in terms of the microbiome. And yes, you can have your microbiome tested, but I don't think we're at a level yet where we have the data to support the overgrowth of particular bacteria being associated with a particular condition and modification of that being appropriate. I would say that, eating a varied diet, what we call eating the rainbow, and taking an over-the-counter probiotic would be likely what would be recommended in the setting of an abnormal dysbiosis. But it is very complicated, and I think we just don't have the data to support interpretation of the results of that as yet.
Great. Just another question there as well, just about the side effects of medication. We get a lot of queries about medication and side effects. Are there any that are specific to gender usually, or is that something that features?
I can't say that I've seen that in terms of a gender specific reaction to particular medications. It's very similar, to be fair. The side effect profile of the medication seems to be quite similar between the genders, and certainly there are common medications that aren't tolerated particularly well by either, and certain medications that are tolerated particularly well by both.
Great. Okay. And just one very final question about Pilates, and is that helpful in terms of managing joint inflammation and associated pain? I suppose this is something that we recommend maybe.
Yeah. So I suppose Pilates is it's a very good strengthening modality and can be helpful in terms of also, I suppose, like yoga can sometimes incorporate aspects of things like mindfulness. There's no direct evidence that it reduces inflammation itself, but certainly can help with pain, particularly actually for back pain. So it's something that we'd often recommend for lower back pain because it really very much focuses on core strengthening. I would say that for a significant number of physical therapies, and that could be like yoga or Pilates or even strengthening, it's very useful just to meet a trained practitioner and have a supervised session first, just to make sure that you're using the correct muscles for the correct activities, so that you're doing it to get the most out of the time that you're putting into it.
Absolutely. Great. Thank you so much for answering those questions, Gráinne. I'm going to hand back over to Gráinne O'Leary now just to wrap things up, because I can see we're getting close to the 7:30 mark. So I'll just put myself on mute. Thanks so much, Gráinne.
And I am just going to, oh, I did what I didn't want to do there. Yeah, I'm just going to wrap up with a few comments about our subsequent 3 weeks. So this is a 4-week webinar series. So we have 3 additional webinars, and you'll see the date. So we have Thursday, the 22nd of May. Which is next Thursday. So the focus next week will be on pregnancy and family planning, and we'll be joined by advanced nurse practitioner Louise Moore and clinical maternity specialist, maternal care specialist Celine O'Brien from Hollow Street. So we'll be delighted to welcome both of those, and that'll be a really interesting session next Thursday. Then we're moving on through the life stages on Thursday, the 29th of May, and the focus will be on menopause and arthritis. And we'll be delighted to have advanced nurse practitioner Mary Gillespie with us on that night. And then the last session will be on Thursday, the 5th of June, and it'll be focused on self-management and lifestyle medicine, and we'll be joined by advanced nurse practitioner Una Martin. So that's the lineup over the next few weeks. So it'll be really going into detail on some of what Gráinne also focused on in her talk today as well. So we'd really encourage you to log in each week, 6:30, to the 3 remaining episodes that we'll be undertaking and delivering to you. Okay. Just a final word to thank our sponsor, UCB, without which we wouldn't be able to bring you this webinar series. And just a last reminder that for all things arthritis, go to our website, please, arthritisireland.ie. And you can also contact us via our helpline, which is 0818 252 846. And look forward to seeing you again next week. Thank you, everybody, and good night. Enjoy the weather.